I'm going to substitute Professor Andelli for this presentation. He has to come back literally yesterday evening, so I apologize for it. So we're going to speak about metal back implants. And since 1974, when the first total shoulder arthroplasty has been proposed, a lot of study has been done on these topics about clinical improvement, radiological outcome, correct positioning, and of course, complication. But if we focus on the glenoid component, we found that the studies focus on the survivorship of this part and the possible pattern of loosening, and so focus on this complication. That is due probably to the fact that the aseptic glenoid loosening is the first cause of revision in total shoulder arthroplasty, and is also 2.5% of all the complication in this kind of implant. This study, published in 2009 by Fox, analyzed more than 1,400 total shoulder, and they found that the metal back implant failed much more frequently than old poly, and also the cementation of the metal back does not offer any improvement in terms of survival. But which of the case of this failure, mainly the thickness of the metal polyethylene composite glenoid that is higher than the old poly, and that's determine a lateralization of the articular surface, and so a possible failure of scapular and rotator cuff, and also an increased moment that is responsible for loosening during the eccentric loading. Also, there is a problem of different material properties between metal, polyethylene, and bone, so we can have a mismatch in stiffness between metal and bone and metal and polyethylene, and an increased risk of polyethylene wear. And the other main cause of failure is the so-called rocking horse phenomenon, that is the anterior and posterior translation of the head during the head movement that determine micromotion and the consequent loosening. This Greek study, published in 2014, that evaluated more than 4,000 prostheses, underlined that the metal back glenoid has a higher rate of incidence of failure and revision than the old polyethylene, and the loosening is the first cause of revision. Also, Pascal Boileau in 2015 concluded that the uncemented metal back glenoid is not a viable long-term therapeutic option, and the conservative duotree with reinsertion of a new polyethylene is rarely because of glenoid bone loss, implant loosening, and soft tissue deficiency. But there is a new generation of metal back glenoid, and what is new with this implant? For sure, the shape, the width, and the length of the central peg, the design, the angulation, and the strength of the fixation screw, the ingrown surface, and the capture mechanism using the polyethylene insert on the metal base plate. As Professor Castagna then in 2010 evaluated 35 consecutive patients at a follow-up of 75 months, treated with a second generation metal back glenoid, and he found there is a significant improvement in constant score, thus no polyethylene glenoid dissociation, and also the most important thing, no need of revision surgery in the follow-up period. Also, Fuentes evaluated the Salmesh implant in a follow-up of more than 15 months, and they found good to excellent clinical result with this implant, and they have only 3 revisions that are due to glenoid component fracture. Again, Merola in a tantalum trabecular metal back glenoid component have the same results, so excellent clinical performance, good function, few radiographic change, and this does not affect the outcome of the implant. If we move to review the literature, a scheme that in 2020 compare the classic metal back and the modern metal back, and we found that modern metal back had a significant lower loosening and failure rates compared to the conventional design. And also the loosening becomes the second cause of revision compared to the first cause of revision in the conventional design. Always Kim compare metal back and old poly, and he found that again, of course, the new modern metal back has lower loosening and old poly increased loosening over time. So at 72-month follow-up, metal back was better in loosening and failure rates, and the clinical outcome, constant score, ASA score, were not lower for metal back than for the cemented old poly. So, which are the advantages of metal back? Of course, the bone ingrowth that provide greater stability, the possible concomitant bone graft procedure in case of severe glenoid bone loss, no complication related to the cementation, and the easy conversion to reverse total shoulder. This review, publishing on the shoulder and elbow, evaluate the use of metal back and bone grafting in bone loss, and we found that there is a comparable rates of revision and an improvement in pain compared to the augment, the glenoid augment, and also to the reverse shoulder arthroplasty. Also, the conversion to a reverse from a total shoulder appear to be shorter with this kind of implant, and so they conclude that using a modular convertible prosthesis reduce the extent and duration of the revision procedure, and so decrease the risk of possible complication of this surgery. This is a patient treated by Professor Randelli in 2001, a concentric osteoarthritis treated with an anatomic total shoulder. Then we have a cuff failure in 2014, and he performs a revision to a reverse with this convertible implant. It's important to remember to use a glenoid inclination that is suitable for eventually a revision of this implant, so slightly inferior tilted. So what about take-home message? Is to forget the prejudice. Again, the metal back glenoid, consider the promising result of metal back, the modern metal back. To stay up to date with the long-term follow-up study, in particular about the modern metal back, and remind the relevance of modularity of this kind of implant. Thank you.